speaker today is Dr. Molloy Das. He is a consultant cardiologist and electrophysiologist at the Newcastle Freeman Hospital, where he specializes in heart rhythm disorders and cardiac device implantations. He trained in the UK initially at Freeman itself, and then went on for further training to Toronto, Canada, and obtained his research MD from the Imperial College London. Dr. Das's interests include catheter ablation of cardiac rhythm disorders, with a particular interest in atrial fibrillation and implantable complex cardiac devices, including CRT therapy and defibrillator devices. He's been a trainer for a couple of trainers. At the moment, one of our trainers, Dr. Lalaj, is training with him in Newcastle. I would request Dr. Madas to make his presentation. Thank you.
Good afternoon. My name is Molloy Das. I'm a consultant cardiologist and electrophysiologist at Freeman Hospital in Newcastle upon Tyne in the UK. My thanks to the organising committee for their kind invitation. And I'll be presenting to you today on 2 decades of AF ablation. What have we achieved? These are my disclosures. So just to start, some historical context of AF ablation. Back in 1998, Michel Hassiger and his colleagues in Bordeaux, France, demonstrated that the majority of triggers initiating AF, in paroxysmal AF, arise from the pulmonary veins. And we now know that pulmonary veins account for around 85 to 90% of AF triggers, though there are other sites of triggers outside of the pulmonary veins, such as the superior vena cava in some instances. This finding led to the development of pulmonary vein ablation, and there has been an evolution of this treatment, starting with targeting of pulmonary vein foci to encirclement of superior pulmonary veins as they were felt to be more arrhythmogenic, to individual encirclement of all 4 pulmonary veins, moving to what we perform currently, which is elliptical encirclement of ipsilateral pulmonary vein pairs with confirmation of electrical isolation. And although pulmonary vein isolation has proved to be a very effective treatment for AF, it does have some limitations. Firstly, although achieving acute pulmonary vein isolation has been readily achievable, particularly with current technology, it has been difficult to deliver durable pulmonary vein isolation due to the development of gaps during the healing process following the ablation procedure. And this is of importance because the number of reconnected pulmonary veins relates to the likelihood of AF recurrence. The second limitation is that the pulmonary veins may not be the only AF trigger or driver site. As already mentioned, in paroxysmal AF, around 10 to 15% of triggers arise from outside the pulmonary veins, but these are much more prevalent in persistent AF due to the development of atrial substrate relating to age, genetics, modifiable substrate factors, and the potential for developing substrate related to an increasing AF burden itself. With regard to durable pulmonary vein isolation, particularly with radiofrequency ablation, a lot of work has gone into identifying the factors that contribute to the creation of durable radiofrequency lesions and consequently to durable lines of ablation. These factors include the contact force between the tip of the catheter and the cardiac tissue, the power delivery, the duration of lesion applications, and the temperature of the tissue being ablated. And then beyond the individual lesions themselves, in order to have a durable line of block, there needs to be attention paid to lesion contiguity. With development over the years of contact force sensing catheters, radiofrequency lesion metrics, and improved 3D mapping, there has been significant progress made with regard to delivering this goal. This is perhaps best shown by looking at studies which have involved protocol-mandated repeat left atrial mapping procedures 2 to 3 months after a pulmonary vein isolation procedure in patients irrespective of symptom recurrence. A number of these studies have been performed over the years, and if we look at this table and look across the table, we can see the progressive development of technologies, including 3D mapping and catheter ablation technology, including contact force sensing. And with this, having started from a very difficult position of a very high PV reconnection rate in the early days of AF ablation, we can see that even 5 years ago, the reconnection rates were relatively high, but there has been a significant improvement over time from that stage to the technology that we currently use, with a proportionate reduction in the proportion of patients and pulmonary veins that are reconnected at repeat study. Now, radiofrequency pulmonary vein isolation can be quite a time-consuming procedure, and it does require precision in terms of lesion placement, as well as substantial operator experience and skill. And furthermore, it's also limited by patient movement and breathing, which can affect catheter stability. And so these procedures are often better performed under general anesthesia. So because of these limitations, single-shot tools and technologies have been developed to deliver pulmonary vein isolation more rapidly and more simply. These include cryoablation balloons, of which there are 2 currently available, a laser balloon, a multi-electrode radiofrequency loop, and radiofrequency balloons, again with 2 currently available on the market. And some of these single-shot technologies have also been studied at protocol-mandated repeat left atrial mapping procedures 3 months after the initial AF ablation procedure. And these are shown in this table here, with, again, relatively low rates of pulmonary vein reconnection at the 3-month point, and again with improvements in these rates with evolving technology. And with regard to clinical outcomes for paroxysmal AF, the Fire and Ice randomized controlled trial compared catheter ablation with the cryoballoon against point-by-point radiofrequency pulmonary vein isolation, and found no difference in freedom from AF at 1 year, with both strategies achieving success rates of around 65%. There was also no difference in safety, but in terms of procedural data, cryoballoon PVI was associated with shorter procedure time but longer fluoroscopy time. So is that the end of the story for pulmonary vein isolation? Well, although subsequent radiofrequency and cryoballoon studies have shown further improvements in clinical outcomes up to around 80 to 90% success rates at 1 year, these tools remain limited by the lack of consistently being able to deliver durable pulmonary vein isolation and the risk of extracardiac injury, particularly to the phrenic nerve, which is especially a problem with the cryoballoon, or to the esophagus. So the future of PVI may be pulsed field ablation, a new development, also known as electroporation, which may overcome some of these challenges. Pulsed field ablation specifically targets cardiac myocytes while sparing other types of cells, including nerve cells and the esophagus, and therefore may avoid extracardiac injury. And in this study, published a couple of years ago, one iteration of pulse field ablation was shown to have a 100% durability of pulmonary vein isolation 3 months after the initial procedure. Moving on then to ablation of persistent AF. As already mentioned, there are more non-pulmonary vein triggers and drivers in persistent AF, and that has in turn led to lower success rates from a PVI approach in persistent AF compared to paroxysmal AF. As a consequence, additional ablation strategies have been deployed over the years, including linear ablation, most typically with a left atrial roof line and a mitral isthmus line, or ablation of complex fractionated atrial electrograms, or CAFEs, which often could result in quite extensive left atrial ablation. These strategies were quite widely used, but the STAR-AF2 randomized controlled trial compared these two strategies with pulmonary vein isolation alone and showed no improvement in freedom from AF with these additional ablation lesions, with indeed a trend towards better outcomes with PVI alone. This outcome has resulted in reduced utilization of these strategies, but nevertheless, focus continued to be made on other strategies that may be helpful in the persistent AF population. So there are alternative empirical approaches that have been deployed. These include posterior wall isolation and left atrial appendage isolation. Posterior wall isolation can be achieved by delivering a posterior box lesion set involving a roof line and an inferior line to box the posterior wall. And there is some early evidence from meta-analysis to suggest that this may have a beneficial effect in terms of clinical outcomes. Recently, a hybrid surgical and endocardial combined approach to treat the posterior wall has been investigated and also shown an improvement in clinical outcome, but this is obviously just a single study at this time. Left atrial appendage isolation has also been investigated in a randomized controlled trial, and again, there has been evidence shown of an improvement in outcomes in patients with persistent AF, but there remain concerns regarding electrical isolation of the left atrial appendage and the potential for loss of contractility of that structure, which could lead to thrombus formation. And so this approach has not been widely adopted. As well as empirical approaches, there are also personalized approaches to additional ablation and persistent AF. Areas of left atrial scar, represented in voltage maps by low voltage areas, are thought to be potential sources of AF drivers. And this is supported by data from the DCAT study, where late gadolinium enhancement in cardiac MRI scans was used to identify the degree of left atrial scarring and fibrosis. And as can be seen from the Kaplan-Meier curve in the bottom left, there was greater AF recurrence seen after PVI in the context of more extensive left atrial scar. And this has then led to a potential treatment strategy of box isolation of fibrotic areas by delivering ablation around the boundaries of low voltage areas. Another personalized approach is trying to identify AF drivers. And in particular, rotors have been implicated as AF drivers and have been demonstrated in previous animal models. So much work has gone into trying to identify and create tools that can identify rotors, and focal impulse and rotor modulation, or FIRM, was the first technology to attempt to do this. Initial results appeared very promising, with a significant improvement in freedom from AF, but unfortunately subsequent trials combined in the meta-analysis shown here have shown no overall benefit. Nevertheless, rotors remain a subject of interest, along with identification of other focal drivers within the atria. And there are a number of different tools currently in usage and being evaluated that may be beneficial in this regard. ECGI body surface mapping combines signals detected from a vest worn on the chest, combined with CT scanning to assess epicardial electrical activation in the left atrium, that may then be able to identify sites of rotors as shown in the bottom left panel. AcuMap utilizes a novel basket catheter involving 48 ultrasound crystals and electrodes, which creates a non-contact geometry of the left atrium, and then uses charge density mapping to try to identify sites of rotational activation or other irregular activation that may constitute AF drivers. And finally, STAR mapping uses contact mapping of the left atrium and looks at electrogram sequences to try to identify focal trigger sites that may be important in the initiation and maintenance of AF. And for all of these technologies, there is some preliminary data to suggest that they may be beneficial, but this needs to be confirmed prospectively with large randomized controlled trials. So what is the future of ablation for persistent AF? Well, at present that is quite unclear. There are questions over whether the main treatment strategy should be pulmonary vein isolation only, or a PVI plus substrate approach. And if a substrate approach is deployed, whether that should be an empirical approach such as posterior box isolation, or a more personalized approach trying to target AF trigger sites and drivers identified through a specific technology. What is clear is that effective and durable pulmonary vein isolation remains critical, and again, pulse field ablation may be the key to achieving this, and it is, I'm sure, for this reason that a number of PFA catheters and technologies are being developed by most of the major players in the AF ablation market. One other factor that we have also learned regarding AF ablation is that it is not always the answer. The prevalence of AF is rising due to an aging population, which is also becoming more unhealthy with increasing rates of obesity, with the comorbidities that are associated with that. And a number of studies, particularly those performed in Adelaide, have shown that there are very poor outcomes from AF ablation when these AF risk factors have not been adequately addressed. If we look at the Kaplan-Meier curve at the bottom right of the screen and focus particularly on the dotted blue line, we can see that patients who had an elevated body mass index, BMI, to begin with, but who made very poor progress with weight loss and also did not improve their cardiorespiratory fitness, had very poor outcomes following AF ablation, even including multiple AF ablations, as compared to other patients who had managed to effectively modify their risk factors. Conversely, aggressive AF risk factor management can reverse AF progression or even resolve AF. And that's again supported by the Kaplan-Meier curve on the left, where if we focus on the solid red line, this represents patients who had an elevated BMI at baseline, but who did make good progress with weight loss and also improved their cardiorespiratory fitness. And this Kaplan-Meier curve shows that a good majority of these patients were able to maintain sinus rhythm and remain free of AF without the need for ablation or antiarrhythmic drug therapy over quite a long period of follow-up through lifestyle modification alone. So this slide then shows some targets which have been suggested with regard to AF risk factor modification, and these are extremely important to focus on with patients who present with AF, whether they are being seen by general practitioners or cardiologists who don't specialize in electrophysiology or AF ablation, as well as electrophysiologists. The different factors listed here include weight loss, aiming for patients who have an elevated body mass index to bring this down to less than 27 kilograms per meter squared or greater than 10% of their starting weight lost, increasing exercise levels, rigid blood pressure targets and treatment of hyperlipidemia, reduction in alcohol consumption and smoking cessation, investigation, assessment and treatment of obstructive sleep apnea, and managing blood sugars with strict glycemic control in diabetic patients. So in summary, after 20 years of AF ablation, there remains an ongoing evolution in therapy. Pulmonary vein isolation remains the mainstay of treatment for both paroxysmal and persistent AF. And to date, durable PVI has remained elusive, but we now may be getting closer to being able to achieve this consistently. For persistent AF, additional substrate ablation may be beneficial, but unfortunately previous strategies have failed to show benefit, and newer strategies require robust evidence to demonstrate that they are clinically beneficial. And finally, risk factor modification may have as much impact on outcomes as AF ablation itself. Thank you for your attention, and I'm happy to take any questions in the session at the end.
Thank you, Dr. Manoidas. It's the question time. I'm sure a lot of us have many questions. I think there may be some questions from the panel.
Hello, Dr. Das. This is Dr. Juan Gunadana, one of the cardiac electrophysiologists in the Colombo Hospital. In fact, I was a training Freeman myself some time ago. And if you look at the last 20 years of AF ablation, it's kind of disappointing, isn't it, that we have really not progressed to a point where we can say, oh, there's 90% success. But I remember the initial studies that we did in 2004, between 2004 and 2006, which was eventually only published in 2010, we had acute success in paroxysmal AF ablation of only about 60%. It was so poor that we felt that we could not even publish it. And since that was of course only pulmonary vein isolation, point by point pulmonary vein isolation. But since then, you're doing all this other stuff like cafes and rotas and lines and all that, there really has not been a significant improvement. Do you think that there is something that we are missing, some kind of substrate that we are missing, or some kind of the reason for AF that we are really kind of missing out, and that is why we are not really kind of progressing in this in improving the outcome of AF ablation?
Thanks for that question. I hope you're able to hear me okay. I think there's a number of points that are relevant to that question. The first issue is that is first of all knowing where to treat for an AF ablation. And that's part of the problem, of course, because particularly in patients, for example, with persistent AF, then we sometimes don't know where to treat beyond the pulmonary veins. So that in itself is part of the reason that our success rates are not as good as they could be, particularly for persistent AF. But the second issue is that even when we do know where the appropriate place to treat is that we haven't been able to deliver that very effectively. So the durability of pulmonary vein isolation, for example, has been a real Achilles heel over the years. And it's only really in very recent years with improving technologies of 3D mapping and contact force sensing and radiofrequency lesion quality markers that has improved matters, and also some of the single shot technologies have also helped. So the ability to deliver durable lesions to accomplish the target that you're setting out to achieve in a long-term way is another Achilles heel as well. And the other thing, of course, we have to remember, and this reflects my last couple of slides, is that when we look at long-term success rates, the failure or AF recurrence over time after the procedure can reflect inadequate ablations, so non-durable lesion set. It can reflect that we've not targeted the right area, but it can also reflect that we have delivered durable therapy to the correct areas, but due to AF lack of AF risk factor management, the substrate has evolved, and the patient has now developed new sources and trigger sites for the AF because of unmodified obesity or continued smoking or uncontrolled hypertension and so on. And we have to remember that AF is an evolving substrate. It's not something that's fixed and we can go and deal with it and it will remain that way forever. There are always ongoing changes which can lead to AF recurring further down the line. So these are all important facets, and it complicates the picture hugely.
Dr. Malloy, I'm Suresh Kottagoda from Sri Jayawardhanpura General Hospital. Now, early, one of the things that tested and failed miserably was the lines, multiple lines which were drawn, which when we were in training, we happily drew quite a few roof lines, flow lines, and which caused more atypical flutters and follow-up, and it was quite difficult handling those patients. Do you still recommend that? And I thought the box isolation is yet another extension of something that was abandoned, or at least should have been abandoned.
So, that's a very good point. I mean, when you look at the STAR AF randomized controlled trial, the success rates of achieving acute block across the roof line and the mitral isthmus line were not terribly great. Certainly better for the roof line than the mitral isthmus line. But this goes back to my point before about it's actually very hard to test whether a strategy works or not if you can't actually deliver that strategy effectively and durably in the first place. I mean, lines, I guess, in some ways are a bit of an extension of some of the surgical techniques, sort of cut and sew, which obviously generally do lead to durable lines of block at the sites of the incision, but aren't always as easily replicated with endocardial catheter ablation, particularly in complex areas like the mitral isthmus, where there can be a requirement for epicardial ablation too. So yes, I mean, I think the usage of lines has reduced significantly over or since the randomized controlled trial because of the issues with potentially creating substrate for macroentrant flutters to occur. Posterior box isolation, I guess, there is some data to suggest that the posterior wall has some particular properties that can be the source of AF triggers and drivers, and that isolating that area may reduce some of that propensity. It's certainly being advocated by quite a number of key opinion leaders, and so is growing in popularity as an additional substrate approach over and above pulmonary vein isolation, which unfortunately on its own does not have terribly good outcomes. And perhaps the fact of the technology that's allowed us to deliver more durable pulmonary vein isolation means we can also deliver lines more durably as well, may mean that it is possible to deliver these approaches more effectively. And so then the question then remains whether that proves in a large randomized controlled trial to be superior to PVI alone, or indeed superior to some alternative personalized targeted strategy.
Thank you, Dr. Das. I have one question to Dr. John Pacey. Thank you very much, Dr. Pacey, for that excellent talk at the beginning. And my question is, I hope you're online.
Yes, I'm listening.
Okay. What factors would make it mandatory at your center or in your practice for you to offer a leadless device for a patient at the current situation, considering the cost factor as well?
Okay, so if we separate it from brady, tachy, and LV pacing, they're really quite different considerations. So from the point of view of the bradycardia pacing, the big difference really is around cost. So at the moment, there's a very major, a several factor cost difference between a standard bradycardia pacemaker and the micro device, and that is the dominant factor in preventing the micro device from taking over the majority of the VVI pacing market. There are secondary factors as well. So there are many, many more people who are able to implant a VVI pacemaker than there are able to implant a micro device. So for example, in our center, there are 2 consultants who will implant a micro device, whereas there are probably, I haven't counted, but there's something like 8 or 9 consultant and a similar number of registrar operators who would be able to competently implant a VVI pacemaker. So that's a sort of secondary issue. When it comes to the ICDs, the subcutaneous option, really there's no cost difference. There's no significant cost difference. So it's really around the capabilities of the device and the limitations of the device. So different people have different thresholds. My argument would be that because of the long-term risks associated with leaded devices, that if the patient doesn't have an indication for a lead, they just need defibrillation therapy, they don't need ATP and they don't need bradycardia pacing and they don't need CRT, then they ought to by default be at least considered for a subcutaneous ICD. And then the most restrictive of all is the LV pacing, because that's currently at an experimental stage. So in order for the patient to benefit from that, they need to be enrolled in a study, even though what is hoped to be the benchmarking study, Solve CRT, has completed. It hasn't yet reported. That hasn't yet resulted in full being taken up fully by regulatory authorities. So it's necessarily the case that patients need to be included in a study or registry in order to benefit from that therapy.
Thank you very much, Dr. Pacey. Since we have completed our allocated time, I would like to thank both speakers, Dr. John Pacey and Dr. Malloy Das, who are joining us amidst a busy Monday in UK. Thank you so much for your time. And thank you
very much.